All right. As I said earlier, good morning, everybody. And once again, thanks, Gloria, for asking Rush to be able to participate and provide these monthly trainings on topics that are certainly right at the ahead of what we're wanting to be able to do in providing services and care to the patients that we see and persons who use drugs in general, but specifically to focus on what might be the cultural implications, health equity implications, and ways to really be able to engage people in care. The topic we'll be talking about today is on co-occurring disorders and how we can really use a better integrated treatment model to be able to help to maximize the outcomes for persons who not only may have a substance use issue, but also a mental health issue. What we'll be talking about today include the objectives of discussing the prevalence of co-occurring disorders. And so how do we know that they might be an issue or a concern in our population? Explaining what is integrated treatment. What does that mean to be able to have treatment for both issues at one place? And then listing some instruments which can be really helpful in screening for co-occurring disorders. Because frequently you might see one issue happening and you're saying, well, this may be related to the substance use, but is it? Or this may be related to the mental health. So being able to tease those factors out will be really important. Miss Gloria, I can't see the um, participant screen so well, so if you don't mind, I'm going to make you the co-host. So
Okay,
if you see someone trying to come into the room, but it's in the waiting room, you can go ahead and admit them, please, because it looks like I can't see that from my screen. So we don't want anybody sitting in the waiting room and can't be able to join us.
absolutely.
Okay. And then lastly, we'll talk about a really novel evidence-based therapy that SAMHSA has developed for all substance use agencies that can really be helpful in treating co-occurring disorders as they present to us in our care. So getting a little bit more in depth into what is a co-occurring disorder. It's actually when a mental health issue, the diagnosable mental, behavioral, or emotional disorder, other than substance use, becomes part of interfering with someone's major life activities. So we think of mental health disorders such as anxiety disorders, depression disorders, or trauma related disorders. And then substance use is when the DSM-5 actually has the defined substance use disorder for, say, opioids, alcohol, stimulants, and so that they meet the criteria for that DSM-5 disorder. And then that comorbidity, or what we call co-occurring, is when those two occur together in the same person. And so the interactions between the mental health disorder and the substance use disorder certainly can worsen the course of both. And hopefully you have the slides that we sent out earlier today so that we can have those available for you to make notes as well. So, how many people have a co-occurring disorder? What we recognize is that most of our patients have a co-occurring disorder. About 50 to 75% of all clients who are receiving
Recording.
treatment for a substance use disorder also have a diagnosable mental health disorder. 3 out of 4 of your clients who you're treating just for substance use likely have a mental health issue. Furthermore, if you're working in a behavioral health center and are treating clients with a mental health disorder, 25% to half of all of those clients may currently or have in the past had a substance use disorder at some point in their lives. So we know that those issues going together are very, very high likelihood. And when we look at epidemiology, and that's the study of, okay, how many people are having these issues so that we can better prepare from a public health standpoint to be able to help and treat them, the numbers also match. About 7.7 million people have a co-occurring mental health and substance use disorder. And that doesn't say which came first, but it says they both have those same two at the same time. So, and this study was actually in 2022 for NIDA, National Institutes of Drug Abuse, when we were talking about maybe 40% to 50% may have a mental health disorder if they also are being treated at that one point for substance use. And about 20% may have that mental health illness. So they saw very similar numbers to the study that had been done on the page before. And sadly, more importantly, is who gets treatment. And it's much, much less. And this is the part that's concerning. There are many effective treatments for mental health and substance use disorders in tandem or the integrated approach. But sadly, over 50% of persons that in that yellow receive neither mental health treatment nor substance use treatment. About 35% receive mental health care only, but no substance use treatment. About 9% get both, that integrated care that we're talking about today. And sadly, about 4% just get substance use treatment, but get no mental health treatment. And as half of the people that are out there that are struggling with mental health and substance use issues getting no treatment whatsoever, we know that that's going to unfortunately impact them negatively and cause problems. And feel free to ask questions while we go along if you have anything that you have a question about or want some more information on. And so when we ask ourselves, how does someone actually get a mental health or a substance use disorder? When we look at mental health, we know that we start with that genetic vulnerability, that some people genetically may be more likely to develop mental health issues. And you'll hear people say that in their assessment with them. Well, my mom had this, or, they tell me that I'm just like my granddad and the issues that I had were just like his. So you'll hear that genetic family history as well as you're doing your assessment. The other thing that we know is the combination of life stressors. So trauma, early childhood events, those adverse childhood events, when you do the ACEs check, all of those may contribute to developing mental illness. And we know that unfortunately, between the ages of 10 to 14, the social changes, moving to peer pressure, elementary school, moving to middle school, we know that the social impact of having additional stress from peer pressure, additional stress from exposure of poor environments may cause those stresses that lead, unfortunately, to mental illness. Now, when we look over here on what they say causes substance use disorder, we actually see pretty much the same thing. Biology and genes, genetic, with a family history of mental health issues, and also for gender, with men being more likely to develop substance use disorders, and that environment that we were just talking about, chaotic household, parents' use, environmental issues like community issues or peer issues, and then exposure to the use of a drug. And then that may change the brain mechanism to lead to substance use. So when I go over the two of those, they sound pretty much alike, don't they? And we know that they are very much alike. And so that we start to ask which came first, the chicken or the egg? We had the old saying that the goose that laid the golden eggs. And now when we have to go buy a dozen eggs, ooh, now it's the chicken that laid the $8 a dozen eggs. Or if we're lucky on that Friday afternoon when we don't want to cook, it's that $4.99 Costco rotisserie chicken that hopefully may come first. But we will ask those same things about what comes first when we talk about mental health or substance use. Did someone have the mental illness? They were self-medicating with a substance. It worsened their mental illness, and so they used more of the substance. Or were they experimenting, as many adolescents do with a substance? And then that may cause issues with their mental health. We know that marijuana is one of the more likely, if you're experimenting at a younger age, to cause mental health issues. Then they increase their substance use to cope with these mental health illnesses, and now they once again have two issues. Or the early experimentation may trigger the mental health disorder, and then they self-medicate and things worsen. So we see them working together, unfortunately, toward the increased problems for the client. And when we talk about what happens in the brain, and sometimes that gets a little hard to do. So I'm breaking it down to really make it easy to look at how the brain functions in what you're seeing and talking about for a patient. We know that the dopamine pathways in the frontal lobe have a lot to do with the development of a substance use disorder in regard to reward for taking a substance, receiving pleasure or euphoria for using a drug, and then having a memory is part of that serotonin pathways, the memory of how that drug may have felt for you. And many people will say they're chasing that first high. That's what they're talking about. the memory of that first level of reward and euphoria. And then when they don't use, they may have issues with their sleep. So we see that issues regarding substance use may actually be fairly similar to what we notice about issues with mental health illness. Because when we think about someone with depression, we notice that they have changes in their mood or changes in their sleep. They don't feel pleasure or enjoyment about the things that they do. Or they feel there's no motivation. They'll say, I don't feel like getting up in the morning. And those are those same pathways that we just talked about for substance use. So when a patient may tell you, hey, I'm feeling really, really nervous or anxious, tell me what part of the brain is working on that, serotonin or dopamine? Anybody?
Did you say when it's happy?
When they're anxious.
Oh, when they're ain't. Oh, is it dopamine?
Uh,
That's
Actually,
that's it. Dopamine.
dopamine, a reward or pleasure. Yes. Now let's do yours, Gloria. When they're feeling happy, what part is
Serotonin. Yes, it's serotonin.
okay? Their mood, they're feeling better. When they're
Mhm.
having problems falling asleep, what part of the brain may be that?
Is it still serotonin?
That's still serotonin,
Yeah.
exactly. When they're thinking, wow, I'm feeling so stressed, I'm shaky all the time. My motor systems are all kind of shaky because I'm nervous and shaky.
Right. It's dopamine.
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 But can't you have
Mhm.
nervousness and shakiness with a mood issue and a substance use
Yes.
Oh,
issue?
so it's both?
Well, it's still dopamine, but they're both illnesses.
Oh, okay,
Mhm.
gotcha.
Well, the point of these is you see how similar each of those issues are. Or when someone is in withdrawal, and not only will they have that shakiness, but they'll also be more irritable, more upset. Their mood will be really cranky. What part of the body, what part of the system is that?
Oh, the
Serotonin.
serotonin.
Exactly. And serotonin is also a part of, as we were talking about when you're feeling good.
Hmm.
So you see how closely related serotonin for mental health issues and dopamine, and the two of them for mental illness and substance use are. That's why it's so easy to say and easy that it happens that issues can co-occur because the same pathways, the same functions are happening at the same time, but for different issues, for mental illness issues and for substance use disorder issues. Does that make sense?
Yes.
That's a really important piece. So I like to kind of stay on this slide for a little bit if we need to. So say someone is, give me a disorder that you can think of, any issue, mental health or substance use. Name
Like
something.
ADHD?
ADHD, exactly. So, where is being able to focus and attention with your memory?
Oh, it's both, right?
Huh? And where is a kid who can't sit still because they're getting up and all over the place, and the teacher tells them to sit down, and they can't sit down because they're moving all the time?
That's dopamine.
That's dopamine. Exactly. And so these issues, and I really like this slide because sometimes when we get into how a mental health issue starts or something in the brain, it
Hmm.
gets a little, it flies, does a flyby. This one really helps you to see the functions of the two systems and to see how closely they may function together.
Mm,
Make sense, guys?
I think so.
Okay. I know Miss Gloria mentioned it. If you guys have any other questions or if you want to ask anything else, let me know. I want to make sure everybody gets this one because this is an important piece.
Hmm.
All right. And so sadly, on any part, and you guys have probably heard me say this before, the untreated mental health crisis and mental illness crisis in our country makes all the issues worse in treatment. Because whether you're initially trying or starting with a substance or having a mental health issue, it's always, sadly, always easier to get a hold of alcohol or drugs
Hmm.
than to get a hold of a therapist, a counselor, or a psychiatrist. And so until we really prioritize mental health promotion, ways that we can help people build resiliency, and recognizing an early intervention for people who do have early illness for mental health, we're going to continue to have these crises, and they're going to sadly continue to work together, the mental health and the substance use, because emotional pain feels the same as physical pain. And if alcohol or substances dull that emotional pain, just like they may dull the physical pain, if you break your arm and get a pain medication prescribed to you, then certainly who's going to want to be in pain when there's something that potentially they think might be relieving them is there?
And Dr. Sarah, I have a question about this slide. Because we don't work so much with mental illness. We do have some resources for clients, but
Okay.
do you have any that you can maybe tell us about? I find that it's very difficult to get patients in to see therapists. I used to work at the hospital as well years ago. I worked for Mount Sinai.
Okay.
And I mean, it was just always, there was always an issue. There was always a long waiting, period, or a waiting list, you
To
didn't
get
miss
them into the psychiatric hospital.
that, or yeah, or just the counseling.
Sadly, as I said, not really funding and providing what we need for mental health services has been a long-standing issue in the US. Um, if we can think of anything positive that came from COVID, one of the
Hmm.
positive things was that telemedicine for mental health services became more and more available, and
Right,
insurances were on board to cover it. Although, honestly, since I worked out west where there were very few mental health services there, we've had telemedicine available for folks for the last 20 years, but it really didn't get more notice and utilization
right,
until COVID, when people couldn't come into the office anymore. So telemed services is one very useful option. Many insurances, including Medicaid, cover telemed services. We can post some links to be able to access that for you as well too. Another important thing that we use for patients who have the anxiety about going in to get treatment is
hmm,
there are a number of actually really good self-help applications on your phone that use those same skills that we've been talking about lately, like cognitive behavioral therapy, like motivational interviewing. And actually, there's one that uses what we call contingency management, which actually helps kind of pay you as you're getting motivated to do better and to get better. Because sometimes we need that initial kind of oomph to get started, that motivation to get going. Because remember, motivation is part of that dopamine pathway that we just talked about. So there are a number of resources that we can pull together to be able to post for you guys so that you have that information. Another issue sometimes is that culturally, some groups, particularly Black and Latino persons, may feel reluctant to go and seek out healthcare or mental health care in particular, because frequently the church and going to church is the resolve for that. And sometimes churches may feel and they give out the information that going to a mental health provider isn't relying on the Lord. But we
hmm,
remind people that Luke, one of the disciples, was a physician, which meant
right,
that Jesus was very
Yeah.
happy working well with physicians. So that we have to work together so that the spiritual community and the medical community come
hmm,
together to help people to get better, and to know that just like, hey, we can pray for the improvements in our health, but we also can work on learning things, learning skills, and if needed to be, take medication to help for the improvements of health. Because no pastor gets upset if you may need insulin for your diabetes, but sometimes ministers have been reluctant to recognize, oh, if you're having depression or having a substance use, you may need a medication to help to overcome that. And unfortunately, that's part of the stigma about mental
I,
health and substance use that if you can put your phone on mute, that way we won't have that extra static. But unless you have a question to ask, but sometimes that may decrease the likelihood that people can feel comfortable with care if they may be kind of getting told from the pulpit, well, going to see a doctor or going to take a medication is taking the faith away or taking that from the Lord. So we work together and actually have a program called Faith in Recovery that
hmm.
helps to educate ministers and educate the religious community that all of these are medical issues. We don't treat one differently than the other. And because sometimes that can be an issue as well.
One other question. I don't mean to hold up the training about mental health resources. There was one years ago called Access. And it was for people who do have mental health disorders. It's kind of a program similar to how we have recovery support programs, and we
Okay.
have all of these different services for people who are in recovery when they
Mhm.
need, and but I don't know if there's anything like that now. What I mean is sometimes there are people who want services, but they have mental health issues that they need to deal with first,
Right.
or we're not equipped, right? So we're not equipped physically in our location to
Supervised
assist
mental
them
illness.
or to
Uh-huh.
supervise, manage, to assist, to have them sit in classes. And,
Okay.
but these are people who are asking maybe for jobs. Okay.
Mhm.
They're asking for training, job skills, but
Okay.
can't, we don't have the capability to have them physically sit in the classroom, if
Mm.
that makes sense.
Well, and for those, I'm not familiar with the Access program, although I can look it up and try to get more information on that for you. Uh, what we have tried to do, and actually what the entire U.S. has tried to do in addressing the mental health issues, is
Mhm.
to provide that 988 uh, behavioral crisis number.
Okay.
That number is supposed to serve basically as the workflow to be able to access immediate mental health services if needed, to
Okay.
be able to access crisis counselors right there in the moment to help with stress, coping of an immediate nature, to help
Hmm.
to the de-escalate an issue if someone's at that point where they're at an urgent issue, but they're not, currently where they're at immediate risk of self or harm to others. That
Okay.
988 number is supposed to be that clearinghouse to say, hey, what's going on?
Hmm.
What do you need? Let's calm down. Let's get you calmed down first. Then to be able to say, do you maybe need hospitalization? Well, let's get you to the emergency department or get a crisis team out to assess you. Are you needing treatment and having some issues? Let's refer you. What insurance do you have? And let's try to get you seen and served. And
Okay.
then if you're just having questions, let's answer those questions and give you resources. So that 988 number is currently, and that 988 number was started last year in July of 2022 to
Hmm.
try to address this burgeoning mental health crisis that we knew already was there, but certainly
Right.
was worsened by COVID-19.
Hmm.
Uh, and we've actually there's a company that actually randomly calls 988 to see if they're getting routed appropriately, so that each state can monitor how that's going.
Okay.
Uh, I actually just saw the CDPH actually just put out a grant to try to hire more people for that call line and services. So I know
Okay.
they're working to try to help develop that.
Hmm.
Uh, and they're working so that people get dispatched to 988 rather than 911, which sends out the law enforcement. Because we know, unfortunately, that a law enforcement team intervening in a mental illness crisis sadly frequently leads, actually almost 40%, to the
Hmm.
person with mental illness ending up dead. So we
Hmm.
don't look at doing that. So that's part of the treatment, not trauma, that the current mayor is trying to address for Chicago in particular.
Okay. Perfect.
Okay.
Thank you. Thank you, Dr. Sorrell.
No worries. But the 988 number is a statewide number that Governor Pritzker's office has set up, and they're continuing to work to look at addressing that. We'll also send at the end some list of resources to make sure that you have some numbers that you can contact. Many people see the commercials for them, BetterHelp. I think they actually tried to help improve the openness of people feeling comfortable, because the fellow that was the Olympic swimmer, Phillips, uh,
Hmm.
is on the BetterHelp, and he's saying, "Hey, I had issues. I had anxiety, even a world-class swimmer, but the anxiety
It
was getting in the
helps.
way of my swimming." So that
Hmm.
they're to be able to cope. And I think that that's another way to try to destigmatize reaching out for help. And so
Hmm.
that's important to do. And when people come to agencies, it's great to be able to have those referral sources. So if you notice they may need mental health services, but you only provide substance use, that you have an agency that you have a collaboration with that you can connect them to. So we'll be happy to send you some resources on that.
Thank you, Dr. Sorrell.
Okay, no problem. So what the integrated model of treatment does is it actually works to do some of the similar things that Gloria was just asking about. It can best be defined in these couple of components: to integrate care, to have both substance use care at least in a line, if not right there in the same building as mental health services, for it to be comprehensive, for it to cover all the issues that may be a part of not only substance use disorders, but mental health. And we know that those are very similar. They may also include medication, they may include therapy, they may include vocational support, housing assistance or support, other social services. So being able to get that at quote unquote a one-stop shop is always really important. They're also really assertive. They really try to help the client to be able to move forward and move to where they can continue to do well and to function well in regaining their functionality in society. And if you notice, the topics today and how I address and not look at it not only from the brain function, but the person's function is how they are functioning, how they're able to make it from day to day in reducing the negative consequences of either their mental health or their substance use issues, to look at things from a long-term perspective, to have short-term goals, but also the long-term to have persons in recovery in both mental health and their substance use, and also to have them independent as well as they can to function. It's motivationally interview based, so it uses a lot of those principles that we talked about earlier in motivational interviewing, and it uses a number of different modalities that we'll talk about that can help make things better. And for the person that you already know, because we've had some training on, but we'll circle by them as well again today. So what are the benefits of having that integrated model? One, it helps with coordination. Just as Gloria was saying just now, having to call for a different place or find different locations, if you can coordinate the care between you or just a couple of agencies, then you're not calling all around looking to try to connect someone. So having things in that integrated model, and that may not always be just one building, but it may be another agency that you have a collaboration or what they call an MOU with. It actually reduces the frustrations for clients because they don't have to go to 4 or 5 places looking for service. It helps them in developing their shared decision making because as part of the treatment plan, and we'll discuss this in a minute, you talk about what are their priorities, what are their goals, and then you help them in motivating that. Families and significant others are always included as this as well, because we know that the community and everybody that's upholding and supporting the patient, whether blood or other family, are right there to be able to help and be involved, and everybody knows the plans and services as part of their program. It's transparent, but it really helps everyone because you're also asking the client to share the responsibility in their development so that they feel empowered about their illness and knowing that they can manage their treatment and recovery for both issues. And it has them allows the client and family to have choices in what they do for their self-management and how they're moving toward recovery so they feel more satisfied with their level of care when you really work together to address everything comprehensively. So, with that integrated model of care thing, we recognize that the best way to treat both mental health and substance use issues is to do just that: treat them all. The mental health issues, any medical issues, because sadly, both groups, people with mental health issues and substance use issues, are more at risk to have problems like high blood pressure, diabetes, potential issues in infectious disease like HIV or Hep C. So we want to make sure that the medical issues are addressed as well as their substance use issues. And we don't necessarily even ask about the causal relationship. We don't ask about which came first. We want to ask what's causing the most problems functionally for you. And then we address it that way. And we recognize that both of these brain diseases, and now you guys know about the brain and how the function of the brain works, can really be treated simultaneously because they're both happening in those similar pathways that we talked about and actually gave a couple of practice examples on. And that's why I like that slide because it helps you to now understand, oh, yeah, well, now I know why these are happening at the same time in someone's brain. You can actually even explain it to your client. Well, the same pathways that help with your mood are pathways that are involved in substance use. That's why you may be using a substance, and then also they're telling me that you're having issues with depression. So that integrated model really has the approach to treat the co-occurring disorders together as the component of the treatment team works on the functionality of the patient to really help address all their mental health and substance use issues. So a really important piece on this is screening and assessment to know where the patient is, where the client's functioning and what's happening or what complex pieces are happening as part of their care. We want to check and see if they're in intoxication symptoms, any withdrawal symptoms, any substance-induced issues, and how their motivation is. Not only motivation for help, like the motivational interviewing, but the motivation and who's behind them, who's supporting them in being able to do better and to try to work on themselves. We also want to talk about their feelings and their symptoms that may be part of a mental health issue. We know that the most common co-occurring issues are sleep related, and now you guys know why from that sleep function on that brain sheet, depression or mood issues, anxiety or trauma, ADHD, and we did the pathway for ADHD on the brain too, as well as personality disorders. And we can see how sometimes someone may present for substance use treatment, but those issues may also be related to mental health. Someone that you're assessing for an alcohol use disorder may say that they're having depression and anxiety, if they may be having those same symptoms relating to alcohol, but they may be also having those before they may use alcohol or after they've had a period without use of alcohol. So that's why it's important for you to assess for both. We know that people who use cannabis may have high levels of anxiety or paranoia, but it may not just be the cannabis or not getting the indica versus sativa weed, but it may also be related to a mental health or anxiety disorder that they may have had prior to that. So that's why assessment's going to be really important. And when you're walking through your intake with a patient and you come up with these questions, this may help you to wonder if the person has just a mental health disorder, just a substance use issue, or if they may be having both. Are the symptoms of their issue that they're presenting to you in excess of what you normally expect or what you see for the type or amount of substance that they may be using? So when you're doing your substance use assessment, and you're noticing, wow, this person is actually having more problems than I see in most patients that are using substances, that's when you wonder about co-occurring. Are they having symptoms even when they're in recovery, even when they're not using? That's when you want to check on that. Did their symptoms start before they started using substances? Oh, okay. Then how is that? That may not be related to their substance use. Or have their symptoms persisted a whole month, 2 months after stopping using a substance? That's when you'll wonder if there's co-occurring. Once again, you're going to check for genetics. Are there any close relatives that have the same or a similar disorder? And can their symptoms be accounted for any other issue or explained by a medical disorder? That's why frequently we may have clients when you may take your clients to a mental health appointment and they come out with a lab slip because we have to check for medical issues that may also cause some of those similar issues. And so what kind of screens can we use? SAMHSA has a tip. You guys have heard of the SAMHSA tips, right? Which are the recommendations on what things you can do in helping with treating your patients. If not, I can send that tip to you by email, Gloria, so you can send that out to everybody on the call. But tip 42 of SAMHSA's work is specifically on co-occurring disorders and how to screen for co-occurring orders. Now, their recommendations are what we call the highest gold standard of care. Now, true enough, in everyday life, it might be a little harder to get all of these tests done, but we'll go over them and I'll tell you what we do in our clinical research. Because if you look at that long list of tests, you're already saying, wow, I don't even want to give all those tests. What about the patient? I'm sure they're not wanting to sit for all those tests. So I'll sit and walk through with you on how we look at doing those testing so that we have all of that data, but we don't do it in a way where it's problematic for the patient. Or the patient's like, I've got to be here 2 hours. No, I don't have time for that. So we'll go over these and then I'll talk with you about how we do them. The first thing we do, and pretty much everyone does, a biopsychosocial assessment. So we want to get their health history. That's the bio part. We want to get their mental health history. That's the psycho part. And we want to get their social history. That's those ACEs, the adverse childhood events, the stressors they had growing up, whether there was abuse or neglect in their childhood, issues like that. If they had difficulty in school learning, which might clue you into a mental health issue, we all want to do that intake as a start. Then we want to check for suicide and safety. And the Columbia Suicide Scale is the gold standard for checking. And have you guys heard of that scale? Are there nods? Are there head shakes? No. I'll make sure if you want, I can post each one of these scales to you guys so that you can have a copy of them and see what those questions may look like. Some
Okay.
of your intakes at your substance use agencies may have some of these questions. They may not. I'm giving you, as I said, what they call the gold standard, and then I'll tell you how we do it, quote unquote, in real life. But the Columbia Suicide Scale is we're recommended as the scale for suicide and safety. The ASI, or Addiction Severity Index, is recommended for the mental disorder and substance use scale. Many of you guys know that is called the GIPRA. Have you heard of that name, the GIPRA scales? You have to do those if you have any SAMHSA funding. The GIPRA, or the Government Performance Reporting Assessment, and you're like, okay, that has nothing to do with addiction, but actually it does have a lot to do with addiction and substance use and mental health because it was developed from the ASI, or that Addiction Severity Index. So that way you know that you're asking about mental health, you're asking about family history. For substance use, we frequently use the NIDA Assist Scale, which asks about current, the last months, the last 3 months, and then last year history or any use history. For substance withdrawal, we use the CEWA protocol. For alcohol use, we use the COW scale or the SAL scale for opioid use withdrawal symptoms. We also have an opioid craving symptom scale that's frequently used. For trauma, we use the PCL now, or the patient uh, post-traumatic client list scale. That's a checkoff list for trauma issues. There's also an ACEs score, which asks when you were a child that this happened to you to see if there were adverse childhood events could be problematic. The levels of care we go over in just a second. So we'll talk with that and I'll show you guys how to use that to determine based on the client's functioning what treatment they should do first. We also use for functionality to the World Health Organization disability scale. And then we always ask about stage of change and readiness so that we can know if someone's in pre-contemplation, contemplation, or if they're ready for action. And we've had that training before, so hopefully everybody's, yeah, those names are sounding familiar. Tanya's mentioned that before. So when we think about an assessment, we want to first engage the client in care. Many times clients will come in, but sometimes you might get clients that are referred from the court or clients that are there because their family has kind of drug them in, kicking and screaming. So you want to kind of engage the client first about their own care and empowering them with that. We've already gone over that with utilizing motivational interviewing. So hopefully everybody feels comfortable in how to use that to develop that rapport. Then we want to identify and contact collaterals, family members, friends, those who care to get information on what they've seen so that you have the patient's point of view and also the person all around them, who they've seen. Well, I've seen him do this or that, or I'll notice even before they started using, he would always like a loner or really shy growing up. And when he would come to family events, he'd just stick in the corner. That may give you a clue that they may have some anxiety issues. You also want to screen for and detect those co-occurring disorders with the slide, using the slide scales that I showed you before that. Then we'll determine where they are in that levels of control to see where we need to look at working with them for their functionality so that with the level of care, we can see what their diagnosis is. The other things we want to look at doing is determining if they're disabled. Do they need assistance or referral for disability assessment? Do they have a functional impairment physically, or mentally, or emotionally that may need referral for care or assessment? And then what are their strengths or support? That's going to be so important to see what they have that they're bringing to the table that can help in how they're doing and that they could use in their resiliency to build up your coping skills. Because as you're working with coping skills, you want to see what their strengths are. You also want to identify any cultural or linguistic needs. Is English their second language? Are they involved in services that they feel if they're at a botanica or going to a spiritual healer might be helpful for them? We always want to know those supports. And then identifying what the problems are and having the client say, yeah, I think those are the top 3 things I want to work on. Then determine, okay, I hear you're at pre-contemplation. Remember those things we could do? What's the ruler? given from 1 to 10, how comfortable do you feel working toward these problems? Remember, that's one of the ways that you can use the motivational interviewing to help with moving their stage of change. And then plan their treatment and have them sign off with treatment. That they know that the areas they're working on, and they're ready to look at helping them to make a difference. And most of your agencies, I'm hoping, are using a screening and assessment very similar. Let me know if you would like some copies or examples of screening and assessment activities. Although if you're seeing clients with Medicaid or seeing clients based on super funding, you frequently have to use the GIPRA scale, which covers all of these elements. Now let's talk about the quadrants of care. And what this does for someone who has both a mental health or a substance use issue is it really helps you to see what area you have to focus on first. So here's really the test of that, which came first, the chicken or the egg, which is more problematic right now, the substance use or the mental health use. And there's several levels. Level 1 is that they have low substance use severity and low mental health disorder severity. Level 2 is that they have low substance use severity, but they have a high mental health severity. So they have more issues and more problems with their functionality right now for mental health than they do for their substance use. Does that make sense? Looking for the nods? Okay. Level 3 is that they have a high substance use severity and a low mental health disorder severity. So right now, their primary problems causing them issues to function is their substance use, and their mental health issues are way down on the priority issue scale. All of their issues right now are being caused by their substance use. The last one, level 4, is sadly both. They have a high substance use severity and a high mental health disorder severity. So they're using lots of substances, but also their mental health is severely impacting their care. All right, so I've gone through all of those quadrants. Did that make sense to everybody? Nods, shakes
Yes.
of head. All right, so you're ready for the test.
Yes.
All right, everybody unmute their phones. Wow, finally the speaker's telling you to unmute your phones. That doesn't happen often. All right, so open up your phones. Let me know. Tell me what severity this person is. A 28-year-old white male from Effingham, Illinois.
I don't
Who,
want to even touch anything.
okay, well, hold up and listen. Let me ask the question, then let me know what your answer is, okay? All right, listen up first. A 28-year-old white male from Effingham, Illinois, who smokes approximately 4 grams of methamphetamine daily, reports that when he runs out of his substance, then he'll start to feel sad, oversleep, and feel depressed until he's able to score some more methamphetamine again. All right, what level is this young man on?
I was gonna say 3.
Okay, Gloria says 3. Who else has an answer?
I agree
would
with
say
3.
I would
Okay,
say 3
everybody
too.
agrees with 3. That is correct. He has high substance use severity and low mental health disorder severity. So your primary goals right now, and that's why this comes into importance. The primary goals and your areas that you're going to work on treatment right now for him are his substance use, because the mental health disorder issues are less. Does that make sense?
Yes.
Yes.
Here's the next one. A 22-year-old Black male whose mother died in 2021 of COVID reports that he has very severe depression, sad mood, poor sleep, and thoughts of death, saying, "How can I live without my mom?" And he reports when he hears his mother's voice calling his name every few weeks and has those hallucinations, he'll smoke a few puffs of marijuana until her voice dies down in his head. What level is he? Not you, Miss Gloria.
Number 2.
2.
Number 2.
Number 2.
Number 2.
All right. Excellent. Excellent.
My
All right.
points. Okay.
5 points.
Mhm.
All right. Now for the showdown for the $35,000 car. What 44-year-old Black female reports she's had a long history of mood swings, agitation, manic episodes, and bouts with the law, and then uses about a quarter bag of heroin 3 to 4 times a day, and then a gram or 2 of powder cocaine from Thursday nights to Sundays when she has to work in sex trafficking. She's
Number
very, all right, what level is she?
Number four. Four.
4.
All right. So everybody wins a brand new car. You get a car. You get a
And I need it.
great. I'm not Oprah, but that makes sense because this now helps you to see when you're talking to your patients and using those assessments to help your patients. Now you can tell what you need to focus on first. Which is coming first, the chicken or the egg? Does that make sense?
Absolutely.
Yes.
Yeah.
Makes so much more help for you guys when you realize that someone has a co-occurring issue. Now you can prioritize what you need to do. All right, so now let's talk about the real life versus what the standard of care is. In that perfect world, we talked about all of those things that we ordered, but in those tests that we ordered, I'll go back to that slide. But in the real world, is someone going to sit down with me for 2.5 hours to fill out all those questions? So let's go through what we do on the here at Rush for our clinical services and research. We always do the biopsychosocial intake, and I'm thinking everybody pretty much does that, correct? We always do some type of intake. We
Right.
always do the suicide
Yes.
because
Yes.
suicide and safety is the number one priority. If they are wanting to end their lives, we can't get them to where they need to want to be in recovery. So we always do the intake. We always do that suicide and safety. For clients that are, and then we, if they're, for clients that are presenting stating that they would like to start uh, buprenorphine or methadone or some type of MOUD, then we check their substance withdrawal because you can't start someone if they just use, or you might precipitate a withdrawal from from the MOUD medication. So we'll do a substance withdrawal screen as well for them too. So those are the main things that we do just to get started. Then we would start somebody on Suboxone. We see them in 2 or 3 days to follow up with them. They've already noticed that their cravings are gone down, so we may do a craving scale. They're no longer feeling like they're in withdrawal, so we know that's improved. Then we will talk with them about, okay, let's get your substance use history. We know that you were using opioids. That was number one. Now let's get that full substance use history. And we'll start with the assist. We may start with some of the GIPRA that asks many of those other questions. Does that make sense? Because when somebody's in that high crisis of, I just got Narcan by EMS, all right, tell me about this thing. Is that going to help me? I'm tired of this roller coaster. We don't want to have them sitting for 3 hours trying to fill out forms. We want to get what they need to do for the priority, then start them in treatment. And then when they come back the next day or two, then we can follow up with some of these other scales. Because knowing that they had adverse childhood issues as a child, is that going to help me right now in the moment when they present in high crisis and high withdrawal? No. So I don't need that for right now. I can wait about a week to get that information. I can wait about a week to get some of that GIPRA numbers to say, okay, what's happening there? What's your history? Things like that. I can wait to get their whole history for substance use until they're a little bit better stabilized. Because who's going to sit there and be calm, cool, and collected explaining to me their history of substance use and abuse when they're already currently in withdrawal? So generally, once they've started on Suboxone, then we'll look at finishing up the GIPRA, get a longer assist. We'll get if they've had trauma, because sadly, with many people who are using substances during that substance experience, they've been traumatized. They may have been raped. They may have had to rape. They may have stolen and had other kind of trauma issues. So we know that trauma is going to be there. So I don't need to know that immediately. I can wait until they're better stabilized. Then I can check their functionality. Oh, before this became more of a problem, you were working, you were functioning. And you're telling me now that you're ready to look at changing. So I already have an understanding of this readiness for change. So do you guys see how we prioritize how we do these screenings, but we still get all of the information that we need? We get the immediate things that we need to be able to address them in that crisis, like the 988 people. We triage them and they've got this high need right now. So we're taking care of the main priority because they're in withdrawal. We've got the intake information. We know they're not suicidal. We know they're in withdrawal. Let's go ahead and start them on Suboxone. They settle down some in the next day or two. Then we're able to get more information and history and fill out some of these other forms to discuss, okay, do they have a mental health disorder? They've had PTSD, or they were actually raised in the foster care system. So we know there's trauma related to that. And then we can see where we need to go from there. Does that make sense of how we do this in the real world? Good. All right, then we always practice harm reduction. Even if someone says they're not ready for treatment, we make sure they have Narcan. We give them the never use alone information so that they use a little at a time. They always use with friends. They take turns, and I'll actually joke. Well, just like you pass the dookie on the left hand side, not everybody's going to shoot up at the same time because we don't want everybody gone. If we use one at a time, then people can see if somebody's not waking up or falling out, they'll have naloxone there available. Then we can discuss what's that most severe issue based on the levels that we just went over. We can talk about what's interfering with their functioning, how we can use CBT, and we've gone over CBT a good deal, and then the other supports like family and peers. So all of these work together to be able to utilize the motivational interviewing that we worked on, the CBT work, and the 12-step activities that you guys already had a knowledge base of in working together to help with the therapy services in these cases. All right. Does this make sense? Do you guys have good information on this? Does this feel like it helps you to understand things better?
Absolutely.
Yes.
Okay.
Yes.
I had a couple of slides that give you some examples, but since it's right at 12 o'clock, I want to make sure that we have time to ask questions. I know some people may have to leave, but I wanted to make sure, kind of give a little bit of a pause point, and I can make sure if we want to go over to discuss some better examples, we'll have a little time to do that. But I wanted to make sure everyone who may have to leave may have questions that they want answered at this point. Marguerite?
Yes. I have a question.
Yes.
I want to know that, turn that down so I can hear. Okay. So I would like to know if we can get even a copy of this, what you're talking about, because I meet with clients all the time. And so this was very, very informative for me to be able to help the clients that we meet with at our center here in Aurora.
Mhm. Yes, ma'am. I sent this out to everyone that had clicked that they would be attending this morning. I'll double check to make sure that it goes out to everybody. But yes, the copies of these slides were made available this morning. We're happy to get you more
Oh,
information.
thank
As well as the example.
Yes, yes. This is Miss Dockery. I have the copies that will be given to the staff.
Okay. Yeah, we'll make sure that
Aurora.
you guys get it.
Okay.
All right. Any other questions? Okay, Miss Gloria, I'll leave it up to you. I've got a couple of slides that just show examples.
Hmm.
So let me know if you want us to go through the examples, and then we can move through any additional questions, because I put us down to be available to 12:30, but I know some people may have to go at 12.
Yeah, we can go ahead and keep going. And for those who need to drop off, they can just drop off. But we can go through those last slides.
All right. Well, the therapy that actually combines these three that we've been talking about, the motivational interviewing, and remember we've had that training, the cognitive behavioral therapy, and the 12-step facilitation, which many of you from the substance use community already had already, is actually integrated in a program called Integrated Combined Therapies. And it uses those three models that are both listed as evidence-based practice to really focus and move a client through the stages of treatment. So you use that motivational interviewing to help initiate the change, help engage them in the process, and honestly feel empowered about being able for finally to have something that they can do to help themselves move forward. Then you use cognitive behavioral therapy so that when they're making changes, then you're coming back with them, you're helping to give them ideas on how to best work on their thinking and their behavior, really to help with the therapy. The thinking, then their behavior changes how they do and their outcomes. And then you use the 12-step facilitation to help them to maintain and sustain the changes. This is actually a larger block of all of those stages. So I'm going to break it down into each of those sections so we can give some examples and you guys can remember them and also ask me questions about what are the activities for each section. So that first one, remember we've talked about pre-contemplation and how do you engage someone in a treatment. You work to build that therapeutic alliance. You encourage the evaluation of what is the problem, the behavior. Help them explore it, but reaffirm that the decision to change is theirs. And then you express empathy, which is sadly something that many of those persons who use drugs and persons with mental health issues don't generally get when they're entering community systems for therapy, because there's still a lot of stigma in reaching out for help. You help them, you raise their ambivalence. Remember, you work through their friction, you roll with the resistance, and you help them to define what are their problems and what are the issues that you want to be able to do. So you're using your assessment, you're outreaching to them, you're giving them that assistance, and you're there while they're stabilizing their symptoms of substance use or mental health while they're in that setup and in that stage. The next stage is contemplation. So you're working on increasing their motivation for change. You're using motivational interviewing to help build their confidence to move them to that. Remember the contemplation and ready for action stage? You're helping to move them there. Then you're helping with their motivation. You're helping them to remove any barriers. You're helping to roll with their resistance and using education and peer groups so that they're working to see that, hey, there are peers that have been able to improve this and that they've been able to do better. And then it's the action phase and maintenance of getting and starting the work and changes. You're helping the client make changes with CBT. You're working with them with their social skills if they have issues with anxiety. You're helping their self-efficacy to see, hey, I can do this. I did this instead of getting upset. And you help to continue to express empathy for them. You're practicing those skills. Remember, we did the role play. So you're helping the clients to role play to take a different action than what they did before and helping them, oh, if I'm feeling triggered, I'm going to do this instead of going to use. I'm going to call a friend. I'm going to go to one of the sober day centers or the sober cafe. I'm going to go and listen online to one of the groups for NA online that's available. So you're helping them to use those services. And then by that time, if they're on medications for opioid use disorder, medications for their alcohol use, or medications for their mental health, they're starting to, as they say, kick in and starting to help with how they're doing. You're training them in stress management and making those better decisions. And you're encouraging them now as they're starting to feel more stable. Now let's work towards supported employment. Let's get you into this work program that EDDR has that can help you with getting back on the job again. You're building on their recovery and they're building a support community of people that can help to encourage them and helping them resolve those problems. Remember that cost benefit analysis for CBT we talked about? They're using those cost benefit analysis to make good change. You're helping to support them for their medication management because pharmacotherapy only works if the medications are taken. Or what I say is the medications are good, but they don't work in the bottle. You have to take them. So you encourage them, hey, if you need a reminder or an app on your phone, you can have clients set an alarm so that it plays a song that they like or makes them laugh, but it also reminds them to take their medication. A lot of my patients, goodness, almost most of my patients like to use that don't worry, be happy as they wake up. So when it beeps at 8:30, don't worry, be happy. Oh, I got to take my medications if I want to be happy. There was the other one that's out there. You may be crazy. I don't like to use the word crazy, but if it helps them to remember their medications, use it. And that way they can help and use that as an alarm to help them to remember to take their medication. Clients with co-occurring disorders may need a regimen so that, hey, when you brush your teeth, then you take your pill. Help them to find those things that they do every day. Plus, you're encouraging them with their everyday hygiene anyway to help to make sure they're taking their medication. Make sure they're working on staying with their medications and adhering to them, because even just missing a couple of days may cause them to either relapse or might need hospitalization. And sadly, pharmacies don't always do well with this. Pharmacies may tell a patient, oh, well, we're out of this medication. We'll have it on Monday. From Friday to Monday, a whole lot can go wrong. So they may contact you to advocate for them at the pharmacy. Hey, you wouldn't let your patient be out of their diabetes medication over the weekend. How are you going to do this with their mental health medication or with their Suboxone, knowing 2 or 3 days off Suboxone is going to cause withdrawal? We frequently have to have these conversations with pharmacies so you can advocate for your client to make sure their medications are available and that they manage them. If someone is homeless, they may need to buy not only a lockbox, but they may need to buy one of those little boxes where they go over to Union Station and keep them in a locker so that they don't get stolen if they're in an encampment. Because unfortunately, violence can happen in encampment where people may take medications. And so when someone steals something, they don't know if they're stealing something like Oxy or if they're stealing something like Prozac. So keeping the medication safe is really important. Also involving family and peers. We know that in real life, families aren't necessarily disconnected from persons who use substances. Families just don't know what to do. They may feel helpless. They may already have felt their own trauma from issues that happen in the family, but they're always generally wanting the best for patients. So helping them to connect to families is really important, or helping them find what means for family, people that are there for them. Even if they may not be related, they may still have someone in their corner that they always reach out to. And research shows that when clients are in services for substance use or mental health, if family or support are involved, and family, as I said, doesn't have to be someone related, but someone that cares. We know that they have better outcomes and fewer relapses because they have other people supporting them. They also have other people that are, oh, they're looking in on them and checking on them. And so using that dynamic of kind of not wanting to let somebody down can be positive. So also it's important that you recognize that sometimes family members can be identified as needing issues when the person who's co-occurring goes for treatment. So it's really important during this time to consider what the stress they may have, the heartbreak or issues or confusion. And it may also unveil that, hey, he's not the only one in the family with a problem. And so, how do we look at addressing that? Encourage family member involvement in developing a relationship with them. Use the evidence based treatments and therapies for family groups that could be really helpful. Treat or refer family members who will come to you after they leave. Joe is here for this, but I've had that problem too. Be comfortable saying, I'm so glad that you let us know because we know that these types of issues, as they say, run in families, but they don't have to keep running to make that generational trauma forever. You guys can put a stop to this issue happening right here. Let's get you started. And then encourage them to attend the self-help groups that are either in person or online through Al-Anon, NAMI, and other services. There are a number of different dual recovery groups that are available that also can assist persons that are working on co-occurring issues together. These are the name of those, and I'll make sure that you get the links for those. So in summary, we know that there are many paths to recovery. It's self-directed and empowering for clients, and we need to look at all the health and wellness issues. So once we assess them, get them started in evidence treatment, get their substance use addressed, get services and peer support and recovery, then we also look for whatever services they may other need for legal issues, HIV services, family services, mental health, and in particular medical, which sometimes gets left out because we know that recovery is a reality for both issues. They co-occur together, but they can be co-addressed together in a way that can really make a difference and improve somebody's life. Thank you guys for the extra minutes to be able to go over these examples with you. And let me know if you have any additional questions.